صباح الخير، الله يعطيكم العافية.
الله يعافيك دكتور، صباح النور.
حياكم الله. أول شيء الله يعطيكم العافية. هي أول محاضرة لكم في سنة رابعة في مساق الجراحة، صحيح؟
صحيح دكتور.
تمام. أول شيء بتمنى لكم التوفيق السنة الحالية إن شاء الله رب العالمين. يعني مساق الجراحة العامة مساق سهل. الكورس اللي بيحتاجه أو الدراسة في هذا الكورس دراسة متوسطة. الريفرنسز اللي راح تعتمدوهم بالأكيد راح نقرأ أو راح تعتمدوا على تكست بوك. أنا بنصح الطلاب دائما يكون معاهم أول شيء سيرجيكال ريكول بالراوند، ويعتمدوا على براوز بالإكزامينيشن، وأي تكست بوك بيشوفوه مناسب ما بتعارض مع جماعة الجراحة العامة كاملة، سواء كان بليد لاف، جرينفيلد، ليكتشر نوت، اللي بتشوفوا أنت مناسب، بالإضافة للسلايدز اللي راح نعطيكم إياهم والسيمينارات اللي راح تقدموها. الليكتشرز اللي بنعطيهم إحنا والسيمينارز اللي بنعطيهم هم مهمين بشكل كبير في الميني أوسكي إكزام. الميني أوسكي إكزام هو امتحان بتكون من 15 20 30 40 سؤال، يعتمد على عدد الأخصائيين اللي راح يحطوا الأسئلة. بيجي سؤال على صورة، الصورة هاي بيجي عليها مجموعة أسئلة صغيرة، الإجابات محددة، فبالتالي اللي ما بيركز بالمحاضرة أو بالسيمينار ما راح يجاوب هاي السلايدز. اليوم إن شاء الله رب العالمين راح نشرح 3 محاضرات وراح نكمل باقي السيمينارز. المحاضرة الأولى راح تكون عن جول بلادر، الثانية راح تكون عن جوندس، الثالثة عن الانال كونديشن. المحاضرات سريعات، كل شيء وارد في المحاضرة مطلوب، حتى لو ما شرح السلايد. دائما هذا أسلوب يجب أن يتبعه الجميع. المطلوب أنك تقرأه من الليكتشر ومن السيمينار ومن التكست بوك نفسه. الآن ما في مصدر ثابت تقول والله أنا هذا الكتاب بكفيني للجراحة أو هذا الكتاب بكفيني للباطني. الآن المعلومة يجب أن تأخذها من أي مكان، حتى لو كان جوجل سيرش، أي مكان، حتى لو من ريسيرش جديد. ادرس، لأنه المعلومة راح تصلك، وتعلم تساوي اكزامينيشن للمرضى بشكل يومي. يزن تفضل. طيب راح نبلش المحاضرة.
بس
تفضل.
في ناس مش قادرين يفوتوا، مش طالع لهم انه في ميتنج على التيم.
إذا في واحد من الشباب بيقدر يساعدهم ودي لهم اللينك.
تمام، هسه بشوف.
دخلوا الطلاب ولا في مشاكل؟
دكتور، هو زي مكتوب بالميتنج ended.
غريبة يعني، هي أنتوا داخلين على الميتنج.
بس انه دخلنا اول اشي اول ما فتحت.
جرب ساعد زملائك. طيب خلينا نبلش. بما انه اللينك بعثتوا لزملائكم. Today the first lecture is about gallbladder disorder. As we know that the gallbladder is a reservoir for bile located in the undersurface of the liver at the confluence of the right and left half of the liver. consists of fundus, body, infundabrium. It's separated by the liver by cystic plane. The infundabrium of the gallbladder make angle with the body and make obscure the common hepatic duct. Carotid triangle is bounded by common hepatic duct on the left, the cystic duct inferiorly, and the cystic artery superiorly. دائما احنا intraoperatively لازم نعرف ونشوف كيف الجول بلادر. As we know, this is the gall bladder which we remove during the surgery, and this is the liver around. The gall bladder located at the bed of the liver between the right and left side. During the surgery, we have to concentrate and to find the cystic duct and cystic artery and clip both clearly to prevent injury to the another organ, especially common bile duct or left hepatic duct or right hepatic duct. The venous drainage or the arterial cystic artery originates from right hepatic artery. The venous drainage is directly into the liver parenchyma or into the common hepatic plexus. The cystic duct arises from the fundabrium of the gallbladder and extend to the joint of hepatic duct. When we remove the gallbladder intraoperatively, we use techniques open versus laparoscope. Especially during laparoscope, we have to see if it is safety triangle to remove or safety position to remove the gallbladder without clipping major organ or without making injury to the major organ like duodenum, stomach, liver, or transverse column. As we see in this picture, we see that there is right hepatic duct, left hepatic duct. They join to make common hepatic duct. The cystic duct join to the common hepatic duct to form the common bile duct. The common bile duct drainage to the second part of the duodenum at the umbilical of Vater. So during the surgery, we have to concentrate on the anatomy to know the exact anatomy we perform, exact anatomical position of the gallbladder to remove. The most common problem to the gallbladder is gallbladder disease and stones and sludge, which makes the different problem to the gallbladder. Disease of gallbladder we can classify to the cholelithiasis, cholecystitis, cholecystolithiasis, biliary dyskinesia, gallbladder perforation, gallbladder pancreatitis, gallbladder polyps, and others. We will concentrate on the major points regarding the gallbladder and gallbladder stone. The gallstone disease or cholelithiasis is one of the most common surgical problem worldwide. Gallstones are abnormal inorganic masses formed in the gallbladder and this commonly in the common bile or hepatic duct. The frequent cause of abdominal anesthesia and emergency most likely in surgical case related to the gallbladder disease, even gallbladder biliary polyp or acute cholecystitis or cholangitis. So we have to take a good history and to perform good examination when any patient presented to the emergency department, especially with epigastric pain and right upper quadrant pain. Although gallstones can form anywhere in the biliary tree, the most common point of origin is the gallbladder. So when we explain to the patient that there is gallbladder stone, the best explanation is to remove the gallbladder because it's the source of the gallstone. It is the source of the problem. We have many types of gallstone, and we have three types depending on the consistency. It's cholesterol stone, or pure pigmented black or brown, or mixed stone. The gallstones are classified according to the predominant chemical composition as either cholesterol or calcium bilirubinate stone. This is one of the stones that we remove from gallbladder. The small stone sludge or the sludge go down to the cystic duct, and if it is too small, it go down to the common bile duct, and sometimes it may cause obstruction to the common bile duct, and the patient presented with jaundice, abdominal pain, fever due to presence of the stone and the sludge. Under normal condition, a delicate balance occurs among the level of bile acid, cholesterol, and phospholipid. But there are abnormality in this equilibrium, and sometimes a major problem during the oversaturation of calcium of the cholesterol, which lead to conformation or lead to make more and more stone in the gallbladder, which lead to gallbladder disease. Pigmented stones are composed of two calcium bilirubinate and appear in two major forms, black and brown. The pathogenesis of cholesterol gallstone is clearly multifactorial, but involve four factors, which is cholesterol supersaturation, crystal nucleation, gallbladder dysmobility, and gallbladder absorption. Hemolysis and liver disease are associated with the black stone. The brown stone most likely formed outside gallbladder and often associated with bacterial infection of the biliary tract. This is an example of black stone and brown stone, and the presence of the stone, the common bile in the infundibulum of the gallbladder. The brown stone, the picture A, and B is black stone. The mortality related directly to complication of the disease and its surgical treatment. Approximately 10% of patients with gallstone have common bile duct stone. Gallstone can cause obstruction of the common bile duct, causing obstruction of the neck of the gallbladder caused bile stasis, which lead to inflammation, edema of the gallbladder wall, which lead to increase or include acute cholecystitis secondary to compromised lymphatic, venous, and ultimately arterial supply to the gallbladder. Later can lead to gangrene or abscess formation to the gallbladder. Women are more likely to develop gallstone than men, with a ratio of 2:1. Classically, gallstone occur in obese, middle-aged women, which lead to popular mnemic fat fertile 40s. There are multiple risk factors for gallbladder stone, including increasing age, female sex, genetics, social factors, lifestyle factor like obesity, also diet, depending on high caloric, high carbonic diet, also high insulin and high triglyceride and high cholesterol. So there are multifactorial that increase or multifactors that increase the gallbladder or gallstones formation. The first step important. The first most important step is to take history to rule out or in the gallbladder disease. By history, the patient most likely presented with nausea, with without vomiting. It may present also, there are some food that increase the attacks of abdominal pain like fatty food. Also, the patient may experience episodic of acute abdominal pain, which called biliary colic, especially after 2 to 3 hours of eating a fatty food. Upon examination, we have to concentrate on examining the abdomen in general by inspection, palpation, percussion, auscultation. But there are 2 signs that we have to concentrate, which is called Murphy sign and Murphy sign, which is a pain on the on palpation of the right upper quadrant when the patient inhales, may indicate acute cholecystitis. There are other signs like fever and jaundice. So, complication of gallbladder stone, as we mentioned previously, maybe it's acute cholecystitis, chronic cholecystitis, maybe it's cholelithiasis, acute cholangitis, acute pancreatitis, also maybe gallbladder perforation or obstructive jaundice. Complication of cholelithiasis, maybe the passage of the gallstone from the gallbladder to the common bile duct may result in complete or partial obstruction of the common bile duct. Frequently, this manifests as a jaundice. So some patients may present with a jaundice, right upper quadrant pain, fever, jaundice. And some patients may be presented with severe epigastric pain after taking history and examination and making full investigation like performing amylase and lipase. The patient may be presented with pancreatitis, which is a major complaint or major complication after gallstone slippage from the gallbladder. Sometimes the patient presented with severe hemorrhagic pancreatitis due to pancreatitis itself, which the main cause is slippage of the gallbladder to the common bile duct. We have to concentrate on the history and examination, because if the patient complains of right upper quadrant pain, fever, jaundice, it's called and we have to know that common bile duct obstruction and which may lead to cholangitis. If there are alterations in mental status and hypotension, this indicates ryanite pentad and the harbor of a worsening condition due to ascending cholangitis. Some patients presented with gallbladder diseases, especially in fatty patients, which most of them perform a bariatric surgery or try to decrease their weight. So a decreasing weight may lead to perform more and more gallbladder stone and such, which lead to complication of gallbladder. So weight loss is one of the risk factors that lead to gallbladder disease. After taking history and examination, and we have to perform laboratory investigation. So we have to concentrate to make a basic investigation to the patient, like CBC. We have to concentrate in white blood cell, hemoglobin, to check if sometimes there are patients presented with severe inflammation. Also, we have to order liver function test to see if there is elevation in amylase, lipase, gamma GT, and to check if there is elevation in total and direct bilirubin. So, if the management, the management depends on the history and exam, and especially on the lab's results. So, after performing lab investigation, we have to perform radiological investigation to rule out or to rule in the gallbladder disease. So, any patient presented with symptoms suggestion of biliary disease, we have to initially starting with ultrasound scan. Then, if the patient diagnosed by gallbladder disease, the management is laparoscopic cholecystectomy, is to remove the gallbladder with the stone. If the gallbladder disease of the gallbladder stones or sludge not identified in ultrasound, we have to make more and more investigation, especially radiological investigation, especially if the patient presented with recurrent abdominal pain, right upper quadrant, without signs of gallbladder stone or sludge or inflammation on ultrasound. We have to start with MRCP, CT, ARCP, also endoscopic ultrasound. If there's still diagnosis uncertainty, there is uncertain diagnosis, we have to repeat imaging after the acute phase of the abdominal pain. If the gallbladder disease diagnosed after using MRCP, CT, or ARCP, we have to perform laparoscopic surgery. If there are problem in the common bile duct or the sphincter of it, we have to make a more and more conservative management and treat as less as invasive procedures. Some patients say that they start using X-ray. The X-ray is less benefit in gallbladder disease, and the sensitivity reaches for 15% of gallbladder stone are radiopaque the stone. But sometimes the patient visited with rigid abdomen, so we have to start to perform X-ray abdomen or X-ray chest to see if there are under perforation. But the best imaging is ultrasound, the most sensitive and specific test for detection of gallbladder stone. So ultrasound finding gallbladder disease and cholecystitis is the presence of stone, sludge, or presence of huge stone or multiple small stone. Also, maybe there is shadow, and sometimes maybe pericholecystic fluid increasing the gallbladder wall, or maybe there is a dilatation of cystic duct or dilatation of common bile duct or presence of stone in the common bile duct. If we cannot reach diagnosis by ultrasound, we said that we can start performing CT scan, rule out masses, or we can start using HIDA scan, which indicate or can help us to reach diagnosis, especially if there is abnormal mobility, like gallbladder disorders, mobility like or biliary including stone or sludge or acute cholecystitis or
دكتور الصوت مش واضح.
is the removing of the gallbladder. So the treatment is to remove the gallbladder surgically versus or open versus laparoscopic surgery. Acute cholecystitis, after the patient presents with gallbladder stone and he does not treat and does not remove the gallbladder, there is maybe sludge of the stone to the cystic duct or common bile duct, which may lead to obstruction of the duct, leading to stasis, leading to inflammation of the gallbladder. Sometimes the patient presented with acalculous cholecystitis due to long fasting and other diseases. The patient presented with right upper quadrant pain, sometimes major after surgery if the patient keeping MBO or dependent on TPN. total parental nutrition. So we have to take more and more history, and we have to make more and more investigation, and to perform multiple imaging, starting with ultrasound. Some patients presented with a high increase in white blood cell or increase in liver function test. This indicates a severity of infection, and the severity of infection depends on admission of the patient, giving the patient IV antibiotic, giving the patient IV fluid, and to perform surgery as soon as possible, especially if there is complication like perforation or jaundice. So we have the jaundice, then we have to remove the gallbladder. Some patients presented with acalculous cholecystitis or presented with calculous cholecystitis, but the problem, the patient is not fit for surgery. So we have to start with conservative treatment, and we have to start with MBO and giving analgesia and antibiotic to the patient. As advice to any patient presented with gallbladder stone or acute cholecystitis, we have to advise the patient to perform or to make cholecystectomy because of high recurrence or high rate of the recurrence. If the stone slip or there are the sludge or the stone slip to the common bile duct, the patient may be presented with jaundice, severe right upper quadrant pain, fever. So cholelithiasis, it's a common bile duct stone, occurs in 15% of patients with gallstone. Increase with age, especially in the elderly, and the gallstone occurs as 15%. Usually condition goes unknown until obstruction occurs. The patient presented with pain, fever, chills, which is classified as a Charcot triad. The imaging, we have to start, as we mentioned previously, with ultrasound. Also, we have to start then with ERCP or percutaneous transhepatic cholangiography. ERCP, it's endoscopic retrograde cholangiopancreatography. It is a technique used to diagnose and to treat gallbladder disease in the common bile duct by insertion a probe inside the common bile duct. خلينا نوريكم صورة. الصورة بعدين. By inserting a probe, inserting the common bile duct and making serial images. After making serial images, we identify the sludge or stone and we remove the sludge or stone using balloon or stent. راح نشرح عنها بالمحاضرة اللي بعديها اللي هي jaundice عن ال ERCP. So the treatment of the common bile duct stone in patients with cholelithiasis and cholecystitis is usually treated by endoscopic papillotomy and stone extraction, followed by laparoscopic cholecystectomy. We have a rare disease called primary sclerosing cholangitis. It's inflammation of the biliary tract leading to the fibrosis and stricture of the biliary system. Most common occur in men between 20 to 40 years, most likely due to genetic cause. May occur in patients with AIDS from infection by CMV virus or other viruses. The management is difficult. We have to start with less invasive management. The patient may be presented with multiple presentation. Some patients present with anorexia, pruritus, malaise, and some presented with fatigue. The treatment is the regular checkup for common bile duct and regular treatment using ERCP by using balloon or inserting a stent in the duct to relieve or to make a drainage, good drainage to the bile from the gallbladder and from the bile system, biliary system. As we mentioned previously, the complication may be gallbladder disease, biliary colic, acute cholecystitis, pancreatitis, and cholangitis. So, if the patient diagnosed as a pancreatitis, we can classify it to mild, moderate, and severe. If the patient diagnosed as acute cholecystitis, we can also diagnosed to mild, moderate, severe, because the management, depending on the condition of acute cholecystitis or cholangitis or pancreatitis, if it is mild or moderate or severe. As example, for acute cholecystitis, the mild, no criteria for moderate or severe, but in moderate and severe, some studies perform that the criteria depending on white blood cell and palpable tender mass in the right upper quadrant, and if there is local inflammation in the gallbladder. The management of pancreatitis and cholecystitis and cholangitis, it's have a major treatment process, but there are some more and more investigation and more attention, especially regarding cholangitis, because the patient need admission to the ICU, regular monitoring, and sometimes patient need to be to perform intubation if there are bad condition to the patient. But acute cholecystitis most likely do not need admission to the ICU and need admission to the floor. Some patients presented with jaundice without pain. So we perform an investigation, we perform ultrasound, there is no stone, no sludge, but sometimes we find that this patient presented with jaundice, recurrent attack of jaundice or persistent jaundice, and on the investigation, the patient may be presented with mass. After investigation using MRCP, MRI, or ERCP, we diagnose this is a cancer or carcinoma of biliary tree, which occur in 2% of people. The prognosis of carcinoma of gallbladder or biliary tract is bad prognosis. Maybe the risk factor is chronic gallbladder infection, maybe polyp, maybe calcification, or anomalies of pancreatic biliary duct. The management of the cancer or the cholangiocarcinoma, it's complicated because it depends on the position of the tumor, the status of the patient, involvement of other organ, presence of lymph node, presence of distal metastasis, and the fitness of patient to the surgery. Most likely, or 2/3, it's called classic skin tumor, to arise at the confluence of the hepatic duct. 1/4 at the distal hepatic bile duct, the remainder of intrahepatic duct. And the symptoms may be progressive jaundice, sometimes pain, right upper quadrant, radiate to the back. Also, patient presented anorexia, weight loss. After complete obstruction or partial obstruction, if there is a stasis of the bile, the patient may be presented with fever, chills due to cholangitis. Palpable gallbladder with obstructive jaundice usually is said to signify malignant disease. Some patients presented also with hepatomegaly, and some patients presented with pruritus. The labs we have to make a basic investigation like gallbladder disease and stone or jaundice, and we have to add tumor markers to make a diagnosis and to start treatment depending on the position of the patient or the clinical status of the patient. The imaging we perform to the patient with suspected cholangiocarcinoma or gallbladder cancer is the same like any patient presented with right upper quadrant pain and suspected with gallbladder disease or gallbladder disorder. Some patients may be benefit of laparoscopic cholecystectomy, especially if the gallbladder disease or cancer, carcinoma of the gallbladder, is intimal and mucosal, submucosal inside the gallbladder, and there is no metastasis or lymph node involvement in the area, or invasion to the hepatic bed. So the patient maybe the laparoscopic cholecystectomy is the treatment for early stage of gallbladder cancer. Thank you. The next lecture, it's about jaundice, is related also. This lecture is related to the previous lecture. As we mentioned previously, that the gallbladder stone may be small, so it's slipped to the cystic duct, or there is a sludge اللي هي بنسميها احنا الترسبات الطينية, sludge or stone that slipped through the cystic duct, which go down to the common bile duct and make an obstruction, which lead to stasis of the bile and make jaundice. The complexity of the bile tree can be broken down into much simpler segment, the intrahepatic on right and left hepatic duct, which exit the liver and join to become the common hepatic. The cystic duct branches of the common hepatic duct and drain into the gallbladder. The common hepatic duct continues down to the duodenum, and it's called common bile duct. Obstruction or inflammation or infection of the biliary tract changes the baseline anatomy and size of various ducts. The normal the common bile duct and pancreatic are less than 8, less than 4 millimeters respectively. The gallbladder is typically less 4 millimeter in thickness. So any changes in the diameter of common bile duct or pancreatic duct or the gallbladder wall indicate there is inflammation, indicate there is a stone, indicate there is sometimes distal obstruction which lead to dilatation of the duct. Patients with obstructive jaundice are suspected to develop a nutritional deficit, infectious complication, acute renal failure, and impairment of cardiovascular function. Postoperative morbidity of the patient with obstructive jaundice is reached up to 20 to 30 patients. So this patient need more and more critical care team to monitor this patient and to make a good assessment before surgery to avoid the postoperative complication. Jaundice is yellowing of the sclera and sclera due to abnormality elevated level of bilirubin in the blood. It can be characterized to 3 different categories, including prehepatic, intrahepatic, or posthepatic. Our lecture today is surgical jaundice, which means that we have to stay only on the posthepatic point, only in the posthepatic. When we examine patients with jaundice, or if we say that we have a jaundice, we have to make an examination, starting from general assessment to the patient, taking vital sign, making hand examination, making face examination, making chest examination, making abdominal examination, because some patients present with jaundice, liver failure, may present with gynecomastia, may be present with spider nevi, spider angioma, dilated vein in the abdomen, not jaundice alone in the eye, may be presented with jaundice in the mucosa of the abdomen, maybe all his body is jaundice, look yellow. So the first cause is the prehepatic. There is an excess and production of bile at overtake a liver with bilirubin and this is the predominant unconjugated hyperbilirubinemia. The most common cause of prehepatic jaundice is hemolytic anemia, which causes excess heme breakdown. Intrahepatic cause are due to parenchymal liver disease with inability to either conjugate or excrete bilirubin. In this case, the fraction of bilirubin that is elevated varies. Barrier hepatitis often has a predominantly unconjugated bilirubinemia. Conjugated hyperbilirubinemia is seen with cholestasis from drug or primary biliary cholangitis. The major concern is a post-hepatic cause or obstructive jaundice. There is an impediment to the flow of the bile due to partial or complete obstruction, extrahepatic biliary passage between the liver and the duodenum. Obstruction can occur with the biliary tract or biliary duct themselves, or more distal with the pancreas. This predominantly causes conjugated hyperbilirubinemia. Careful history taking clinical examination and investigation point to the cause of jaundice. Serum biochemistry confirms the diagnosis of jaundice with an elevated of serum bilirubin, usually more than 40 milliliters when detectable clinically. An obstructive pattern is recognizable in the other liver function tests like high alkaline phosphatase and mild increase in concentration of transaminase. Surgical jaundice is suspected over medical cause or jaundice in the following scenarios: history of abdominal pain and fever, painless jaundice with weight loss, pruritus, and clay color stool, conjugated hyperbilirubinemia with elevated of alkaline phosphatase and gamma GT, and enlarged gallbladder, abdominal base mass, or lymph node in left supraclavicular area is considered advanced disease. So we have to distinguish the cause between the surgical jaundice and medical jaundice because the treatment is depending on the type of the jaundice. Maybe the jaundice is due to malignant cause or benign cause. So we have also to make an investigation like ultrasound, MRCP, ERCP, to rule out if there is malignancy or not. So in jaundice, especially obstructive jaundice, we have to concentrate on the cause of obstructive jaundice because also the treatment in obstructive jaundice depending on the cause. But in general, the rule that the gallstone is the most common cause of obstructive jaundice in surgical or obstructive jaundice. Then become the malignant causes. As we explained previously, the Charcot triad Raynaud Bentad, the Charcot is right upper quadrant pain, jaundice fever, but the Bentad is right upper quadrant, jaundice fever, as we have to add hypotension and altered mental status, which indicates severe condition, cholangitis, ascending cholangitis, which need admission to the ICU or critical care unit, and to make more and more management and aggressive management. The obstructive jaundice, we have to concentrate on a major point that some patients may be presented with distended or engorged superficial epigastric vein, which called caput nodosa. Sometimes may be presented with rectal varices. بعض المرضى بيجيك بقول لك دكتور انا عندي بواسير، تستغرب بتقول يعني بتفحصه بتقول هاي مش بواسير، هاي dilated vein because this dilated submucosal vessels due to backflow of the veins due to the jaundice because this is some of the complication of the liver disease and jaundice. And if you perform therapy to this patient, he will end with severe bleeding because it's not hemorrhoid, it is dilated veins from the portosystematic shunt or portosystematic anastomosis. Imaging and labs, same as previously, we have to order for ultrasound, MRCP, RCP, sometimes we need CT, and some patients we have to perform endoscopic ultrasound. In details, the ultrasound we have to perform because it is easy, cheap, and it's most sensitive and specific for gallbladder disease. The finding is presence of stone, sludge, varicocystic fluid, increased thickness in the gallbladder wall, presence of the stone common bile duct, dilated common bile duct, or presence of masses. Then, if there is jaundice and we have to treat the jaundice and to relieve the jaundice or remove the stone, we have to start with the second investigation is MRCP, then ERCP. ERCP, it is endoscopic technique used to insert a probe inside the common bile duct to make a dilatation if there is a stenosis or stricture, to insert a balloon, to remove a sludge, and to make a brush biopsy if there is suspicion of malignancy. If there is intermittent jaundice, we have to make a more investigation to start with using MRI, because maybe there is a stone in the common bile duct or there is suspicion of malignancy in the patient. So not any jaundice or not any patient presented with jaundice, it is simple, or it is most likely due to stone or sludge, because if there is no stone or sludge on ultrasound or ARCP or MRCP, we have to think more about malignancies. If we perform an ultrasound and there is no dilatation in the biliary system, so the cause of jaundice, maybe it's extrahepatic due to cholestasis, maybe there is metastatic hepatic disease. So the jaundice patient with liver metastasis may have a biliary obstruction due to infiltration and obstruction of bile duct at or near the porta hepatis. The intrahepatic duct are dilated, but attention may be drawn to the metastasis, missing the opportunity to palpate symptoms by relieving the obstruction. Other signs of liver disease may be present on the ultrasound. So, in making assessment of the jaundice, if there is dilated bile duct, most likely there is gallstone. If yes, we have to perform MRCP. Stone NCPD, we have to perform ERCP or percutaneous colonogram or surgery. If there is no dilatation, it depends on clinical picture, we have to perform MRCP or liver biopsy. Then we start to make a more investigation like CT, if there is mass or not, if there is a stone disease or not. If there is mass, we have to perform endoscopic ultrasound, biopsy, or laparoscopy or diagnostic laparoscopy to reach the diagnosis. So now, the most important step is the management of the obstructive jaundice. The first step in management of obstructive jaundice is based on the acuity of the disease and clinical status of the patient. Patient with hemodynamic instability, coagulopathy, or renal dysfunction need to be quickly resuscitated prior to managing the specific etiology of the obstruction. The presence of cholangitis, often it is difficult to stabilize the patient until the obstruction is relieved and source control of infection achieved. Bile duct stone. Several options are available after investigation have relieved bile duct stone. Selection depends on the physical condition, comorbidity, previous attempt, if the patient had a cholecystectomy previously, availability of equipment and theaters and anesthesia. The best to remove the stone from common bile duct and site of umbilical bladder is to perform ERCP, and the success rate reach about 90%. But during performing ERCP, there may be some of suspected injuries or perforation to the duodenum, the common bile duct, or injury to the gastroduodenal or branchial gastroduodenal artery. So it's a good diagnostic test to treat and diagnose gallbladder disease or common bile duct disease, but there are complications of or major complication like bleeding and perforation after performing ERCP. After performing ERCP, sometimes we use balloon and sometimes we use stenting. So stenting, we insert a stent in the common bile duct to relieve an obstruction and make good drainage to the bile. But maybe there is immediate complication or late complication. Concentrate on this slide. Immediate complication may be or perforation or bile leak, which may lead to peritonitis, peritonism. If it's not managed, may lead to death, sepsis, death. Late may be recurrent jaundice due to displacement, sludge, overgrowth by neoplasm, or erosion to the adjacent vessel. Thank you. This is the first lecture and second lecture about the jaundice. ناخذ بريك 10 دقائق على 9 و25 دقيقة بنبلش بالمحاضرة اللي بعديها.